Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers run compliant and successful agencies. OC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. Today, we're going to be talking about face-to-face encounter requirements. And now I'd like to introduce our industry guests for this episode. We have two members of the OC Advisory Board on the call today. We have Nanette Minton, Senior Clinical Coding Manager with Mac Legacy. And we have Lisa McClammy, Senior Clinical Education Consultant, also with Mac Legacy. Thanks so much for joining us today.
Hey, Jan.
Yeah, right. Thanks, Jan. I'll let Lisa kick it off here. We wanted just to have a little bit, we don't have a bunch of slides today, but we just wanted to really have a great dialogue regarding face-to-face and some particular scenarios that we had recently come across, and give the audience a chance to maybe ask those questions they might have.
Sounds great. So before we dive in, I just want to make sure that everyone knows they can ask those questions in the question box if you have any. So be sure to submit those and we'll try to get to as many as we can. And then I'll turn it over to you folks. Thank you.
All right, sounds good. Thanks everybody for joining us. We're, like Nanette said, we're just going to start off with a few scenarios and talk through those. So Nanette, you have a patient that goes to urgent care. They were referred to your agency as a result of that for exacerbation of heart failure. Their Lasix dose was increased and they need teaching and weight monitoring. This patient saw their PCP 3 weeks ago in the office for a UTI and has completed the antibiotics with no UTI symptoms now. Can you use that urgent care encounter as the face-to-face if the primary care physician or PCP is the one that's going to be signing the plan of care?
So Lisa, this is a great question, and the answer is no. So it's something that, it hasn't changed in the rules, but we seem to have a hard time in the industry applying those across the board. This is a community referral. When you have a community referral, the physician that is the certifying physician, whoever's going to be the one signing that certifying statement for the plan of care, and we'll talk a little bit more about that later on, making sure you understand that, then it has to be that same physician, not the urgent care physician. And so if the patient had been admitted to the hospital, then it would be potentially a whole different ball game as to what we could have done regarding that face-to-face. But no, we cannot use that.
Awesome.
Perfect. One of the things the other question we were gonna ask, I think, is to talk about, so what does it look like if you have a face-to-face encounter for someone, does it matter if you're in a pre-claim review state, or what does that look like for you, Lisa?
So pre-claim review or our review choice demonstration as a whole, and pre-claim reviews, the most common of the selections in RCD is pre-claim review. But when you're talking about pre-claim review, there are absolutely no new requirements whatsoever. I think where, people kind of get a little bit hung up is they think, well, your face-to-face is getting more scrutinized. There's more, you have to do more. But what the deal is every single face-to-face is being looked at on the front end. But there's absolutely no difference in what face-to-face requirements there are for pre-claim review. So, again, nothing different. And I know, when we got started with pre-claim review, agencies had patients that had been on for a long time, and you would find that, well, they might have had a visit, but was it really related to the primary reason for home care, which is the other than being in the time frame, that's the main thing. It has to be related to why you're getting that patient for home care or for home health. And, you know, again, it's just with pre-claim review, every single one's being looked at. And every time you go in and submit for pre-claim review, you have to submit that face-to-face documentation. So it's getting looked at again, even over and over. So the answer to the question is there's no different requirements, but they're being scrutinized heavily if you're in a pre-claim review state.
Yeah, that just makes it so tough. I think one of the, you know, working with pre-claim review, you know, submitting those claims personally and looking at those denials, you know, they say that the face-to-face, the diagnosis that's assessed on that actual face-to-face encounter only has to be related to. But really what you end up finding is it has to match much more closely than really what people are understanding. And therein lies the difficulty. I mean, if you're using a face-to-face that was done 2 months ago, it's likely that the reason for home care may have changed. So it becomes increasingly difficult. Well, I ran across a scenario recently as well. So the agency was struggling. So they got a referral from a urologist that said this patient needs home health services. The patient's having issues with, I think the diagnosis ended up being like other urinary incontinence because they wanted to use that as primary. But multiple issues, and the urologist is the one that said, hey, they need to, you know, he ordered home care, there was a face-to-face. Well, when the agency sent that plan of care, the urologist would not sign the plan of care because it had other things on there not related to urology. So it was really kind of a difficult situation. So we were kind of working with the agency on what you could do, because you don't want to leave all those comorbidities off of that plan of care. You know, there was a visit with the PCP that could have been used as a face-to-face, but you know, it didn't support really very well the primary urology diagnosis. So it was kind of a quandary. So Lisa, you had come up with some great thought processes on potential resolutions to that. I don't know if you want to expand on that.
Sure. You know, when you're talking about the plan of care, the first thing I want to kind of mention here is, you know, when you go out to do an assessment, you really should be getting that verbal order from the provider, whoever that is, whether that was the urologist in this case or the PCP. You need to be getting that verbal order discussing the plan of care, making sure they agree with the plan of care. So that's one thing I just want to mention there. So honestly, that probably should have been taken care of in the very beginning. But since this agency, you know, didn't really know that urologist wasn't going to sign and find out later, one solution might be, or a couple of solutions might be, you know, that face-to-face being done by the urologist really needs to sign that plan of care. So they probably need to contact that urologist and, you know, figure out a way for them to collaborate with the PCP and let the PCP manage the non-urology things on the plan of care by writing an order on that plan of care somehow to designate, you know, certain things to the urologist, certain things to the PCP. The other solution that I was thinking about was, you know, if the face-to-face from the PCP would fit, because it would, you know, they would have to see that PCP. So if that PCP would be willing to do that within the 30 days, then you could have the PCP sign the plan of care and put the urologist as accepting orders from them. So there's a couple of scenarios there, but you have to be real careful with that face-to-face and make sure, you know, it's a community referral.
Exactly. And so that, yeah, those were some great scenarios on how to manage that. You know, because those things come up every day. The other thing that kind of, you know, we were kind of talking through is that, if in fact you were able to get that urologist to sign that initial plan of care, that, certainly at research or at any point, once you get that initial face-to-face and all that documentation taken care of, they could choose, you could coordinate with that PCP for him to take over as the certifying physician, as long as you had that documentation, and then that would change at recertification. But something else to consider, because they're definitely, without that coordination, we're seeing, denials on that for sure. Okay, well, those are a couple of scenarios. Lisa, I think we talked about maybe just, going down the list of 2 or 3 things that, just reiterating the basics of the face-to-face, if you want to kick that off.
Absolutely. One of the questions that we get occasionally is does the homebound criteria have to be on the face-to-face encounter? And the answer is kind of a non-answer almost, but the face-to-face encounter has to support the homebound status, and of course the need for skilled care. But we're not going to get a face-to-face encounter hardly ever that has the criteria documented the way Medicare requires that documentation to be in order to support eligibility for home health. So let's just talk about just some of the basics to make sure, more as a reminder than anything. But so elaborating on that just a little bit. So when the provider, when you get that face-to-face encounter, it has to look like the person you're describing in your homebound documentation. If it doesn't, then you're going to have a problem, and that face-to-face is not going to be supportive of that homebound. So that provider needs to, document their functional decline, their mental decline. There may be confusion, maybe the reason for them being homebound, whatever it is. That documentation that you're saying on, most people put it on the plan of care in some area, what the homebound criteria are, and I'm going to go over those in a second, but that encounter, face-to-face encounter, has to support that. If it doesn't support it, and it looks like a, independent person that can, take themselves to the doctor and to wherever, then you're going to have an issue with homebound status, because that face-to-face is going to have to support it. So let's just talk briefly about, the face-to-face encounter. Number one, has to be, of course, within 90 days prior to or 30 days after the start of care. I'm just kind of reviewing here. It has to be related to the reason for home care. And like Nanette said earlier, it's got to be really closely related to. I mean, a lot of times you'll get diagnosis codes on the face-to-face that don't exactly match the way that we code according to the coding guidelines, but the diagnosis itself has to be the same. The reason for home care has to be the same, very, very closely related. And it also, of course, has to be done by the certifying physician or an allowed practitioner, non-physician practitioner, and we know what those are. As far as a reminder, when it comes to the homebound part of that, again, there needs to be supporting documentation about the patient to support the homebound criteria. But, and I find this when I'm doing chart audits, that this is probably the most confusing piece to clinicians. It's how to document the homebound criteria. And normally there's a template on the plan of care somewhere. Sometimes it's in the intervention sections. It can be different places depending on your EMR, but it will say the patient needs a person, a device, or special transportation. And the template says that, and then it's not changed to be specific to that patient. So the first criteria that this patient has to meet is they either have to have a person, a device, or special transportation to leave the home, or there has to be it has to be medically contraindicated. So They don't have to have all three of those, but it needs to be very specific. Does the patient need a walker? Does the patient need a person and a walker? They can need more than one, but they don't have to. They only have to have need one of those things to safely leave the home: a person, a device, or special transportation, or have that medically contraindicated documented reason as to why they can't leave the home. So if your patient doesn't meet one of those, then they're not homebound in Medicare's eyes. So you want to make sure that it's very clearly documented, specific to your patient, what it is that that patient needs. And again, leaving that template written like that without making it specific to the patient, you will have issues with. Then once they meet that first criteria, then you go to the second criteria, and this gets a little muddy too when you're seeing the documentation. They have to first have a normal inability to leave the home. That's pretty easy most of the time to document, but then they have to, the leaving the home has to be a considerable and taxing effort. And it can't just say it's a considerable and taxing effort. Again, that's a thing we see a lot, is that's in the template, that's the way it's written, and it's not edited specific to the patient. And it can be any number of things, you know, as to why it's a considerable and taxing effort. You know, the patient can't ambulate more than 10 feet, 20 feet, whatever, without having to sit and rest. They have pain in their shoulder and they can't manage their walker, so they need a person. Whatever it is, there's a million different things it could be, but you have to make sure it's very specific to the patient. Nanette, you want to add anything to that? I said a lot of words there.
No, that was great, Lisa. I was just sitting here thinking that, you know, one of the biggest struggles, it's you know, again, and one of the best ways you can increase the likelihood of that documentation being accepted if it's ever reviewed is to tie the homebound status back to that primary reason for home health. You know, something specific to that diagnosis that's happening. And so again, they're not looking at cookie cutter care plans. And it also looks at medical necessity. I know this is not what this call is about, but we've just seen some recent denials for, you know, when your plan of care, let's say you have wounds and you don't have measurements and you don't have all the things, you know, denoting, you know, what's really happening with the patient, or it's just skilled nurse 1 week 8 to observe and evaluate unstable disease processes. Well, that's not going to get you, that's just not enough information for medical necessity. So it kind of all ties in. I guess really that face-to-face is just that golden document that you just have to make sure, you know, is there, and looking at all of that, making sure we're clear. Something else you and I talked about, Lisa, as we were preparing for the call that I thought would be good that we clarify and just kind of make sure the audience is aware. Can you talk about what does it mean to be certified and a certification statement?
Absolutely. So, so on your planning, most all of the EMRs automatically put that certification or recertification statement on the plan of care. Where it, I want to mention in the beginning where it needs to be, and we have had a few denials based on this that we've had to deal with. It needs to be directly above the provider's signature. So I know that sometimes the paginated plans of cares, the provider will either sign on the first page and it's at the last page, or vice versa. And they'll only, and it's okay for them to only sign one page if it's paginated, you know, page 1 of however many pages and 2 and whatever. But truthfully, we've seen some denials, and I will be honest with you, sometimes I think it depends on the reviewer, but irregardless, we have seen some denials when the provider signature was not directly underneath that statement. So I don't have that statement right in front of me, but basically it says, I certify or recertify that this patient, you know, needs skilled care, nursing, intermittent nursing, or PT, ST, or the continued need of OT, that statement, y'all know what it is. And then it also, a lot of times, depending on how you configure it, and like I say, that's sometimes an EMR thing, it'll even have the date of the face-to-face where you can document it in that statement, which makes it very, very convenient when the provider has to document the date of the face-to-face. If it's coming from an institutional referral and somebody else, a hospitalist or whoever is the one that referred to home health, and the PCP signing the plan of care, all they have to do is acknowledge the date. And if they do it right there and they get it correct, then that will suffice for acknowledging that date. So you certify, of course, at start of care. I certify this patient is in need of the home health, and then you recertify them when you do your recertifications at the day 56 to 60. Again, that's part of one of the conditions of participation, that plan of care will be periodically reviewed, and that's how that provider does that certification and recertification for home health. I will tell you, if you're, another thing we have learned over the last few months, if your provider changes from the start of care to your research, you have to have some way that you document that handoff, or that transfer of care from one provider to another happened. The patient has the right to choose. You can do that through a communication note. It's not, at this point, at first they said it had to be a signed order. They have completely taken that away from the website. It does not say that anymore, but there still has to be some communication documented in your patient chart that patient changed from one provider to another.
Yeah, that is lots of good information for sure, Lisa.
Right. A lot of little things we've run into over time.
Exactly. Absolute knowledge. Well, I think that covers most of really the questions we were going to talk about. Before you cover just kind of an update on the latest OASIS Q&A, Jen, did we have any questions?
We did get a couple of face-to-face questions. So this one seemed like it, I don't think we talked about the specific situation. This listener says, we have a wound care center that sends over the order and the encounter, but they won't follow the plan of care. They defer that to the primary. So the plan of care gets signed by the primary care, but the face-to-face encounter is the wound care. What are we supposed to do in these scenarios?
Yeah, that is such a tricky situation. And so a couple things, and Lisa, jump in here if you have anything you want to add. So I would want to know initially where that initial referral is coming from. It's fine if they were in the hospital and now they're, being referred, because as long as that certifying physician documents that he is aware of and when the face-to-face occurred, but he's following the plan of care, he's certifying the patient, that's not a problem. Where it gets really tricky is the community referral. Right. And so one of two things have to happen. And honestly, the community referral has to be done by that physician that's signing the plan of care. So if the physician running that wound care clinic, or however they're doing that, won't do that, then you're going to have to send your patient to see that PCP. And you can use all the documentation from the wound care clinic to send in as support for the measurements and for all of those things, for the wound care orders, as part of the medical necessity. But that certifying physician is going to have to be the one to actually do the face-to-face. Lisa, am I leaving anything out?
Nope, that's exactly right. And, it makes it hard. It makes it hard on the agency, and it makes it hard on the patient. They have to make another visit. I mean, I get it, but as a community referral, that's the way it has to happen.
Yeah, absolutely. And the part of the issue is if you're not in a pre-claim review state that's kind of already had that pre-approved, if you will, you're not going to necessarily know that until you get into some type of audit or review status, and then they deny that. So that's why it's really important to make sure obviously you're following up and getting it done on the front end. Just that initial paperwork. Do we have everything in order, or within 30 days we're getting everything we need? And from a coding perspective, it delays so many things when you don't have that face-to-face initially, because then you can't really code if you don't have the face-to-face, because then it's going to be wrong. It's just a whole host of issues. But okay, Jan, I guess we're ready for that next question.
Okay, well, this is just a follow-up to this question. Now I have a third question.
Okay.
And that is, just to be totally clear, in this situation, you would actually have to get a whole new face-to-face from the admitting MD.
Yes, that is correct.
Okay, cool. All right, that was a quick one. And then the other question we'll just run by real quick, and I think you did cover this in general, but let's just put a bow on it, and what's the best thing to do here when we have to get a clear diagnosis for admission from the physician, and the face-to-face encounter is still listing that vague diagnosis. What's the best thing to do here?
Sure. That's a very loaded question, but I understand. It's what we do every day in the coding world when we're looking at things. So I would just say, this is where the relationships that the agency has with those providers is very important, and making sure you're looking at all of the documents. Have you looked at all the documents to be sure? So let's say I get a referral, and on that face-to-face it says OA, muscle weakness, OA, and back pain. Right there. I don't, unless I know that the OA is in multiple sites, or I have some other specific cause of the back pain, I'm going to have to go back to that provider to try to understand. Now, what I will say is there's a couple of things. Some providers are really good and they'll provide additional information, or they'll do a little addendum to their face-to-face. I've seen them do that to clarify that, but you can't have a separate order. It has to be documented on that face-to-face, and really not just in the list of diagnoses. So I become a little detective, and I actually go through all of the things there, and I really will try to hone in. For instance, do they have chronic pain? Did they refer them for OA and muscle weakness, and it's we don't have a specific site of the OA and it's not multiple sites? Do we have chronic pain in there anywhere? So is there a way to tie those generic diagnoses to those generic codes to that? I've even had somebody that was referred for muscle weakness or weakness and debility, and can you think about what else is going on, like muscle, I'm trying to think of the code that I want to tell you, muscle deterioration of multiple sites. So there's some alternate diagnoses that kind of fit in that. And I know I'm not giving you, clear information, because every single report that you're looking at, when you're looking at all those diagnoses, it can be different. But like, I know if somebody is referred for RA and we don't have anything further, I try to look for, is there an other code, and can that agency, call the doctor and get an approval for that? Because the diagnosis code itself doesn't necessarily have to match, but is there something related? So I don't know if that's helpful or not. So it's too gray, but I hope that at least provided a little bit of insight.
Thanks, Nanette. I think that did. All right, so those are the face-to-face questions that we had. Let's move on. We're going to run a little over this episode, but folks can always listen to the recording if they have to hop off this live broadcast. So I'm going to move us on to the industry update. And I think, Lisa, did you have a little something to share for us here?
I want to just briefly go over the January 2025 OASIS quarterly Q&As. There were only 5, and I can summarize 3 of them pretty quickly. So the bulk of it this time was about the non-Medicare, non-Medicaid OASIS collection. I really don't like the way that it says all payer or non-med or all payer in most places, because it's really truly non-Medicare, non-Medicaid. It's everybody. So even private pays, your charity cases, everybody, you're going to have to collect OASIS on. So the first question in the Q&As was the collection times. What OASIS time points are required for the non-Medicare, non-Medicaid? That didn't change at all. So the OASIS collection times are exactly the same. You're just adding those additional payers and non-payers, non-Medicare, non-Medicaids. The second question this time was for the phase-in, and will we be able to submit just the voluntary start of care OASIS for a patient with a, I call it MU90, I'm old, MU90 date between January 1, 2025 and June 30th, 2025? Or would we be required to submit all subsequent for that patient as well? So what they're saying here is if we start a patient submitting those OASIS, we submit their start of care, do we have to submit all of them if we're in this voluntary time? And the answer is no. So even if you choose to submit the start of care during the 1/1 of 25 to 6/30/25, any subsequent assessments, and they list them here, transfer, resumption, recert, other follow-up, discharge, death at home, all of that for this patient are also voluntary, including those time points that occur after July the 1st of 25. So even after it gets to the mandatory time, if this patient's MU90 start of care date falls between January 1 and 6/30 of 25, it's voluntary. Any or all of them are voluntary. I think that's where everybody's getting a little bit hung up. Just remember, whether this patient as a whole, any of the assessments, whether they're voluntary or not, depends on the start of care MU90 date for that patient. So anybody that was before January 1st, start of care MU90 date, you will not submit anything. You can't. It's going to reject it. Non-Medicare, non-Medicaid, I'm talking about. You won't be able to. But during this phase-in time, you will be able to submit those assessments, but it's voluntary. And again, even the ones that occur, the time points for that patient that has that start of care MU90 date between January 1 and June 30th, any subsequent assessments are still voluntary. You don't have to start submitting them on that patient after July 1st. So that's the second question. Then the third question that has to do with this, do we need to discharge and readmit our non-Medicare, non-Medicaid patients who were on service prior to December or in December prior to January 1? Anyway, the answer to that, whether irregardless, is don't discharge and readmit anybody. Base your either don't submit the OASIS or voluntarily submit the OASIS. Base all of that on your start of care MU90 date. Once you get to July the 1st, any start of care MU90 date on or after that date, it's not voluntary anymore, it's mandatory. So you have to submit them, any patient with a start of care MU90 date on or after July 1st of this year. Lots of questions about that, but don't discharge and readmit based on this at all. And then we had a couple of other questions. The fourth question was, when determining accurate codes for the OASIS items that require clinical assessment, and the examples that they ask about are height, weight, functional status, and pressure ulcers, can we utilize information from a previous care setting, or must the codes be selected based on an assessment from someone in our agency? And the answer is, you should base those off of an assessment by someone in your agency and not directly on documentation from previous care settings. So the height and weight, there's not a question there. It absolutely says that your height and weight has to be measured by agency staff period. So that one in the guidance is very, very clear. When you're talking about functional status, you know, you're looking at the time in the home in the previous 24 hours, so you can collaborate when you're answering those functional items. So, you know, potentially you could ask somebody about the 24 hours previous. And then on pressure ulcer injury status, you want to assess that skin. You don't always, and they do allow that you can collaborate. If you can't, absolutely cannot do it on the first visit, you can collaborate. It's never recommended. It is always recommended that you do that full skin assessment on the very first visit to establish your baseline. Okay. And then the last question had to do with payment sources. It was asking the difference in private insurance, which is a response 8, versus private HMO or managed care, which is a response 9. And it explained that private health insurance is traditional insurance provided by private companies. It's usually individuals or employers that purchase that coverage. And then private managed health insurance is a type of private insurance that contracts with a network, and the examples are your HMOs, your PPOs, EPOs, or POS plans that use those networks. And it gives you a healthcare.gov website to go to so that you can look up any payers. And that was the questions for January of this year. I thought the all payer or non-Medicare, non-Medicaid, that's where most of the questions are, and it is a little confusing, but I hope I explained it well.
Thanks so much, Lisa. That's definitely helpful. All right, I'm going to move us on to a new segment that we're launching today, and this is the Scenario Spotlight. So this new segment, we're going to read you a scenario. It could be a coding scenario, could be an OASIS scenario, and we'll read that to you one episode, and then on the next episode, we'll give you the answer. So you can think about that scenario and come up with your own response, and then compare it to our panelists' answer next episode. So our first scenario is a patient is admitted to home health with a significant decline with their COPD following a recent hospitalization. The patient lives alone and can complete all ADLs and IADLs slowly without assistance. Per the medical record, the patient's respiratory decline is thought to be related to the lack of money for proper heat and increased dampness and mold at home. Patient also states that they do not take their meds as prescribed due to the lack of money for both food and meds. The admitting nurse writes a progress note and contacts the provider for a social work referral. What would be the best coding assignment for this scenario? So please think about this scenario and prepare your response over the next few weeks, and then you can check it against our panelist response when we have our March call. And now I'm going to advance to our OC member discount. If you'd like to learn more about face-to-face, as we've seen from this call, it gets complicated. Decision Health's face-to-face answers is a great guide to mastering home health and hospice face-to-face requirements. And if you're an OC member, you receive a 20% discount on this book. So click through the link in the handouts to order this resource. And now I'd like to move on to what's new with OC when we share updates from the Association of Home Care Coding and Compliance. If you're an OC credential holder, we'd like to invite you to take our annual survey to share your feedback about our credentials. Just follow the link in the handouts to access the survey, and everyone who takes the survey will receive a documentation tool as a thank you. So thanks so much for sharing your input, and we hope to hear from you on that survey. If you're listening to a podcast version of this show, you'll find the handouts on the OC website along with the recording under resources and then free webinars. That's the same place that obviously you can access the recording if this is an episode you want to re-listen to or share with other folks. And we hope you enjoyed this episode of OC Talk. Thanks so much, Lisa and Nanette, for all the great information and answering those questions on the fly so detailed. I really appreciate it. And thanks to all of our listeners for tuning in. We hope you'll join us again for our March call when we'll be talking about social determinants of health. And in the meantime, If you'd like to re-listen to this episode or a previous one on the go, you can now find OC Talk on your favorite podcast app, or you can listen to the recording and access the handouts on the OC website. And if you have any suggestions for future guests, topics, or ideas about the format of the show, just send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening. We'll see you next month. Take care.
Thanks, Jan.
Thank
Thank
you.
you.